It's a pleasure and honor to speak to this audience and to represent the organization. I wanted to acknowledge Dr. Kimberly Applegate and Dr. Maria Perez as co-workers on this project, as well as the entire C3 committee who have reviewed the project in turn. So the task was to update the current ICRP web-based module, which was struck in 2001. It was titled ICRP Radiation and Your Patient, a guide for medical practitioners. And I have the website there, and when you get the slides, you can go to it, or you can go to the website when you want and look for it. And it was subsequently translated into Spanish in 2009. It's also on the same web page, sequential with the English version. One of the important things when we had this task is what do we want to put into these modules? What do we want to put on the web? And the information environment is quite broad. There is a plethora of credible sources on radiation risk, radiation safety, best practice, appropriateness guidelines. And I'm pleased to show this one at the bottom here. It's a new fledgling group in Canada called Canada Safe Imaging, which is somewhat based after Image Wisely and Image Gently, which I had a part in forming. So we have to look at what we're going to produce in the environment of what's already out there. So our goal is to provide healthcare providers, and we've changed, we wanted to broaden the audience for this task, for this publication, to all healthcare providers, because there's a lot of chiropractors, dentists, nurses, nurse practitioners, the veterinarians who use radiation in addition to physicians. So it's this broad spectrum. Students, so we're all students in some way, form, or another, lifelong learning. But we wanted to ensure that they all had information on radiation safety related to their particular practice, to recognize existing sources of information, which I've shown you, and to identify key pragmatic topics and questions. And to deliver this information in a very friendly, user-friendly, succinct question and answer format, sort of one page, and we'll need the help of a good web publisher to make it snazzy and appealing. And in this context of many providers of such information, we have to try to show what does ICRP, well, we want to highlight what does ICRP contribute to this topic. So before I get to the topics, I realized when preparing the speech that we, collectively, are not the audience for this talk. The audience for this talk are the people who are going to read this that are not as generally knowledgeable as this room is in health physics and radiation protection. So the audience is for all of us to communicate this information to them. So this talk is about how we intend to do that, because it's the process of communicating what we do for a living to individuals who do a lot of other things for a living but have to know a little bit about this. So it's how do we condense our message for them. So the topics that we've chosen to date are what is the ICRP, what is the International System of Radiologic Protection, what is ionizing radiation, how is it measured, how much natural radiation do we get, what are the benefits of diagnostic imaging and interventional procedures, what are the general risks of radiation, ionizing radiation in pregnancy, and ionizing radiation mostly in the form of nuclear medicine for breastfeeding women. And understanding this is a C3 kind of topic, so I understand that the radiation protection is to patients, public, workers, and the environment. This somewhat focuses on patients and occupational. Future topics. What are the risks of low-dose radiation? Ethics related to the use of ionizing radiation in medical research, interventional therapeutic procedures, radiation therapy procedures. Now, many of these topics we've heard or will hear about in this symposium as sort of cutting-edge talks about where we're at with these things, and we're open to any other suggestions for specific topics that you think should be included. Now, communication is the key, and I love this graph from ICRP 121. To me, it really conceptualizes and summarizes exposure, absorbed dose, equivalent dose, and effective dose. But our goal is to take something like this, which has a lot of caveats and a lot of context and a lot of science and information. It's changing all the time too, as we change our tissue weighting factors and we change our radiation weighting factors. Communicating this to healthcare practitioners in a way that's meaningful. That's the goal. So it's not as trivial a task because we keep changing our minds a lot to where we set the bar in some of these things. So one of the problems that I'll talk about later is the fact that our truth is relative. We change the bar, we change the truth, and we have to keep changing the message we give. And that really is confusing to the end users, and I'll talk about that. So the first example, and I'm not going to read these texts because these are snippets from paraphrasing what's going to be covered in this topic for the web and for a publication. But I'm going to talk to it in what Claire Cousins talked about yesterday, the future of the ICRP in plain language, because that's what we're going to try to convert into plain language. So what are the benefits of diagnostic imaging and interventional procedures? And Pedro quoted a really early ICRP publication today, not to impede the radiologic diagnosis. I think one of the things we have to do is step back and realize that the message that this is going to the people that this message is going to, are people who are treating patients with signs or symptoms, and they're trying to intervene on their behalf to give them the best medical advice and treatment and follow-up. So they have the patient's benefit, the patient's health as their first priority. So part of what we have to recognize is that in a constellation of complex medical care, that they want to choose the best test for the patient in front of them that gives them the best answer to manage them. And we have to provide assurances that if that best test uses ionizing radiation, and people generally follow the ICRP recommendations, that is safe practice. I will reinstate that later, that is safe practice. Because we talk about what's safe and what's risk, but at the end of the day, the physician or the nurse or the chiropractor or the dentist who treats a patient and recommends a CT or Panorax dental, they have to feel themselves that what they're doing is safe practice. And part of our communication is to condense all the stuff that we know into a way that they feel comfortable. We talk about risk, we're transmitting risk data, they're receiving it and reflecting whether or not it's safe. So we have to understand that paradigm. It's interesting that the natural radiation is always used as a comparator. Well, we give you this, and then you live a year here, you're going to get that. So that's a comparator. And we have this generic value of about 3 millisieverts per annum of exposure from space and the ground. And most of our exposure, depending where you live anyways, Denver is a different story from Seattle kind of thing, is from radon. And I think it's important to understand generalities of how much radiation we're exposed to, but to also understand some of the nuances. So just to give you an example of these nuances, here's a picture of the arithmetic mean radiation radon levels by country. And I've got one arrow in North America where I live. That's Winnipeg, Manitoba, the center of North America, geographic center of North America. And I have one arrow in South Korea. And you see that based on this map, there's a difference of risk between the two countries, arithmetic mean. That's based on general geological surveys. But that isn't actually the story, because if you take these maps and look at them, this is a blown up map of Canada, you will see it is not uniform. So where I live, my basement levels were 300 megabecquerels per meter cubed. I put a subsurface decompression in my basement. My levels are below 50 megabecquerels per meter cubed. So even we give these messages about background and average, if we're going to go after radon as a particular topic, which is topical now, I think people have to realize that even house to house and neighborhoods have different levels. So we have to be somewhat general in what we discuss, but understand that the nuances are really important. What are the risks of radiation to babies during breastfeeding? So in nuclear medicine, if we have a breastfeeding woman, we have different recommendations based on the radiopharmaceutical we inject. And some have no significant change in breastfeeding practice. Some say, well, if we have to give you radioiodine you should stop breastfeeding completely because of the length of time before the amounts in your breasts are low enough that it won't affect your baby's thyroid. It's really important that people who communicate this to patients make the patient feel that their baby is safe. At the end of the day, if we're doing a bone scan and we say we recommend you stop breastfeeding for so many hours, and then your baby is safe. That's really important for the mother to hear, based on best practice. And so, and we try to avoid nuclear medicine studies in breastfeeding women if we can, but if the clinical demand is such that we need an answer that's only answered by that test, and that's considered to be the ideal test, we go ahead with it and we make the recommendations and we reassure the mother. Because that, we want them to feel safe. And the system of, the International System of Radiologic Protection came up a number of times in the seminars. And we, as in this room, are really good at the science part and the experience. And the values is what we really got to pay attention to when we communicate to the audience that this is going towards, because it's their values that drive whether or not they feel our recommendations make them or their patients feel safe. So that's the values, the societal values in which the recommendations are put in, and that mean a different way of communicating it. So the examples for this, as have already been alluded to many times, are the justification that the benefits outweigh the risks, that if you're going to change a procedure that has a higher ionizing radiation than the previous procedure, you have to justify it. Again, these are people with illnesses that need clinical decisions made and management decisions made, so the benefit usually outweighs the risk, but you have to make the best decision you can based on the evidence available at the time. And you need to optimize your system, your quality assurance, your settings on your protocol so that it gives the lowest dose available. So there's a problem with communication. We had a dose survey of all of our CTs in my region. We do over 600,000 imaging procedures a year in my region, which a lot of them are CT. So we did a dose survey of all our CTs, and it gave a range. The press got hold of that range. They had, and this was an investigational, heavy, aggressive press that wanted to talk about which has the lowest dose, which of your CTs has the lowest dose. And to them, that was what, we should send all our patients to that one CT in our whole region of 1 million people that we cover. Well, we just couldn't administratively handle that. So I had to deal with the fact that different CTs have different doses because they're different vendors, they're different machines, and they treat different people for different indications, so you can't compare. They're not really apples to oranges, right? So they said, well, then why are you so, you talk about the future and that we're going to have lower doses. Does that mean we're not safe now? And that optimization, we keep optimizing to lower the dose, but yet we say what we're doing is safe. We have to be able to communicate that apparent discontinuity to people. And so they asked me on live TV, well, if what you're doing is safe, why are you trying to lower the dose? And I said, well, because we can. If I can give you one aspirin to get rid of your headache, why would I give you two? The risk of an aspirin is phenomenally small, and you bump your head, you could get a stroke. It's phenomenally small, but why would I give you 2 aspirins? So it's just big. We have to reassure them that what we're doing is safe, and of course we're going to try to lower the dose and make it safer, but that doesn't mean what we're doing now is not safe. And that was brought up yesterday with our Ando talking about lessons from Fukushima, where when the regulator changed the levels, the immediate response from the public was, wasn't it safe before? No. Oh, what are we doing? So we have to learn to communicate whenever we change levels or we make things better for lower dose. That doesn't mean what we're doing now is unsafe. Dose limits don't necessarily apply to medical practice as described by the ICRP in their documents, and diagnostic reference levels are coming in as potentially a system-wide administrative quality control to look at making sure that your fleet of equipment has no outliers that are really not keeping to sort of mean, median, or percentile doses. So that's sort of the example of perhaps dose limits, not at the patient level, but at the indication level across the system. So, and I have a fairly short talk, so you'll have more time for questions and answers. I thought a bit more about rooting this publication into what do we actually want to achieve? And we want to achieve a sense that we can communicate risk intelligently to other healthcare practitioners so that they feel comfortable and safe practicing and talking to their patients about the benefits and risks of procedures. And if they need an ionizing radiation procedure, they feel comfortable about that. They also feel comfortable with radiation safety practices and achieving the lowest dose appropriate. That's sort of the goal. And I used to work with the federal government, and they gave us ministerial briefing note training. And that framework, which I'll describe, actually fits well with what we're trying to do, with the caveat that we have to actually be ethical and honest about it. So, the framework is we're going to do CTs on people. We are aware of the risks and the benefits, you know, and we're monitoring. As new information becomes available, we're going to continue to reevaluate the risks and benefits and take the appropriate action. And at the end of the day, patients, staff, and the public and the environment are safe. And if you listen to any government, high-level government press release, you will see three elements. We're aware, we're monitoring, and the public is safe. And that is a formula that people, from a public health point of view, when you have an outbreak and you're trying to manage it, people want to be told they're safe. You have to make sure they're safe. You have to be honest that they're safe. But that is a nice package. And safety is, and I got a typo here, sorry, this morning I typed it. Safety is not defined at zero risk. That is not, safety is defined as the lowest possible risk to achieve whatever benefit or whatever remediation or whatever intervention is needed to be taken. Because I couldn't walk across the street with zero risk, so that doesn't mean it's not safe. So I think this kind of framework, again, the target audience is individuals that need to be reassured that we're providing the best evidence available to ensure that their practice is safe from a radiation protection point of view, their patients are safe, their workers are safe, the public is safe around them, and not as much for medicine, but the environment is safe. And that's my talk. Thank you very much.